It's now moving into the science sessions. Our first plenary is the pathogenesis group. My wonderful colleague Naomi Walker, please come up, and Threnison and Leopold, we can wait up here.
Good morning, everyone. And thanks again to our previous speaker for those really powerful words. So my name's Naomi Walker. I'm a senior clinical lecturer at Liverpool School of Tropical Medicine. And together with Sarah Auld, I co-chair the Pathogenesis and Risk Factors Academic Committee. And I'd just like to start introducing this morning's session by kind of recapping where we were at the second International Post-TB Symposium, when the academic committee reviewed the literature on mechanisms of post-TB lung disease. So we conducted a focused review looking for evidence specifically informing mechanism in this area, and we found that really specific research focusing on the pathogenesis of post-TB lung disease was lacking, but that we could, from the literature on the pathogenesis and immunopathology in TB, extrapolate to some extent. And we came up with some consensus areas that we really felt should be the focus of research going forward. And we published this in a review in October of last year, summarising for the scientific community where we felt that efforts should be focused, and that's just a figure from that paper there. And so on to the committee that was convened for this symposium. I'd like to thank my fellow committee members who are listed here. As you can see, they're from a wide range of academic institutions from across the world, and they are all actively researching in this area. And I think what we can see now, a couple of years later, is that really there is a lot of work now going on in this field. And so I'm pleased to introduce for tomorrow morning's workshop that we will have a range of research presentations that we have collated across 4 thematic areas. So we have a group on prediction and risk factors, one on interventions and host-directed therapies, one on host-pathogen interactions, and finally on models and morphology. And so I'd like to encourage you to come along to this workshop. There will be oral presentations in small groups, really to facilitate active discussions, and you'll have the opportunity to rotate around several of these groups to benefit from those interactions. And so on to the work of this morning. We have got 3 talks. First, on morphology of post-TB lung disease from Professor Threnison Naidoo. Then Assistant Professor Leopold Tinchu will be presenting on host immunity and bacterial diversity and how this influences post-TB lung disease pathogenesis and host-directed therapy. And then finally, Sarah Auld will be presenting on what we can learn from study of pathogenesis in other respiratory diseases. And so these will be 3 short talks, and then at the end of the session we'll have time for short period of time for questions. So without further ado, I'll hand you over to Threnison.
And good morning, everybody. So I'm an autopsy pathologist. I'm much more used to the graveyard shift. So this opportunity to kick off a session is a refreshing change for me. I'm from Walter Sisulu University in the Eastern Cape, where we greet with Molo, but I'm based at the Africa Health Research Institute in Durban, where our greeting is Sanbonani, and my native tongue is Telugu, where we say Namaskaram. So welcome to South Africa, and I'm very proud to be sharing with you some pathological perspectives on post-TB lung disease. So much of the discussion has focused on defining diagnostic criteria for post-TB lung disease. And I'm not a clinician or a radiologist, but I think the parameters that have been established relate largely to clinical and radiological parameters because those are the accessible ones. So, the worsening functional impairment after microbiological cure with corresponding imaging findings that speak to inflammation, ongoing fibrosis, possible cavitation, bronchiectasis. Now, what are the pathological correlates for these clinical and radiological parameters? Because that seems to be the gap in the field. But as diagnostic pathologists, we've been describing these features and reporting these features as sequelae and complications of tuberculosis. So it's typical of pathologists to come in and say, we've known this all along, but if you give it a name, we will describe it. That's what we do. So as soon as you give this a name, we're going to be able to establish the morphological correlates for the clinical and radiological manifestations of post-TB lung disease. So fortunately for us, we have a very good tissue program at the Africa Health Research Institute, where I work as a research pathologist with Audrey Steen. And we've built a substantial tissue repository over the last decade in collaboration with the local cardiothoracic surgeons and anatomical pathologists. And in KwaZulu-Natal, there's a very unique surgical management program of pulmonary TB that in May 2025 is actually going to celebrate 60 years. And at the last symposium here, Audrey and I told you that the surgeons are missing from this conversation, and I'm proud to say that we brought Dr. Rajbun Madansen and Dr. Munir Habish, who are cardiothoracic surgeons who run this program very successfully in Durban, KwaZulu-Natal. They are with us in this audience, so please feel free to engage with them on the surgical management of post-TB lung disease. When systems work, they're performing 1 to 3 emergency or elective surgeries for post-TB lung disease per week. And because of our long-standing collaboration, we have an ethics-approved protocol whereby these patients are consented prior to surgery, and they actually very graciously donate their tissue for research purposes. We use it for basic and translational research, and we supplement that with a post-mortem cohort. So we have established a tissue repository that captures the clinical continuum of TB, from latent, subclinical, active to post-treatment, which then includes the post-TB lung disease cohort. And it's also representative. South Africa is a very multi-ethnic population, so it becomes globally representative. It has all the comorbidities that you can mention, including HIV co-infection, and drug susceptible and drug-resistant profiles. Just a shout out to the surgical program that's run there. It's not new to the world. Dr. Madansen and Dr. Abish have published quite extensively on the success of their programs in both adult and pediatric patients. Right. So as promised, I'm going to show you the morphology of post-TB lung disease. It does get a bit graphic, but I don't think it's going to be off-putting, and there's a while till lunch, so it's not going to turn your stomach. So let's remind ourselves, this is what a normal lung looks like, right? It's reddish in color, it's spongy in consistency, if you could feel it. You've got bronchi in there, that's at the hilum, and they don't reach the surface. They should not, because your airways divide. And then, lo and behold, we have post-TB lung disease, right? Macroscopically, that means with the naked eye, we see fibrosis, that's the white bits, bronchiectasis, so this would be your dilated, crowded bronchi, they dilated almost to cystic capacity. You may have cavitation, often colonized by a fungus ball that we call a mycetoma, and even where you suspect that there might be residual normal tissue, it's often dark in color, and that's indicative of the hemorrhage that actually occurs. Remember, these patients clinically are characterized by recurrent minor or major hemoptysis, right? There's heterogeneity in the gross morphology, but what is definitely consistent is that this morphology that we get to see in the lung is completely underestimated by the radiological images, right? Right, so even in the post-TB, after microbiological cure, you will have residual tubercles. So these are the whitish bits among the beige. Sorry, my arrows have disappeared, but you can see it. And this is a whole lung specimen. You see complete loss of lung volume from an adult, right? A normal lung in the adult weighs 400 to 600 grams. This is completely shrunken and fibrotic. Right? There's no residual lung tissue left. Right? Having said that, and while we speak of specimens, every case is a story, and we appreciate that these are TB survivors. There's a narrative behind every specimen. For example, this was a 16-year-old child who had multi-drug resistant TB, and her TB history actually spanned about 12 years from the age of 4. Right? Good news is she is alive and well as far as we know, but you can see what post-TB lung disease has done to this child. This is an example of some of the specimens that we received, and when you open it, surprise, surprise, or perhaps no surprise. Right? Complete effacement of lung architecture by a combination of caseous necrosis and fibrosis. Right. But as I said, we know that each and every one of our specimens, whether it's from survivors of TB or post-mortem specimens from decedents, we appreciate that there's a human element to it. My prof always taught me, we cut with our hands, we see with our eyes, we think with our head, but we always report with our heart. So we never ever forget that there's a human behind everything that we see. But we work very, very hard in the research laboratory. Every specimen that we receive is processed in its entirety, and we do spatial mapping so that we can actually match every tissue block to everything that we see microscopically, and then we can match that even to any downstream analysis that we do. Right, so as you can see there, and with a whole lung specimen, it's not just representative lung samples that we do like we would do with diagnostics. We actually process the entire thing. So in a single lung specimen, even the shrunken ones, we can get about 500 to 700 blocks that I have to go through. Kept very busy, no time even for a haircut, as you can see. Right, so that's the macro. And then as pathologists, we tie to our microscope. And this is some of the images that I want to share with you. But before we even get to it, let me just give you the background that basically the alterations we are seeing are architectural, so structural abnormalities, and then cytomorphological, meaning cellular abnormalities. There's a striking temporal and spatial heterogeneity, even within the same patient, even within the same tissue, even within the same tissue blocks. So that's within about 2 by 2 centimeters of tissue. And what I've prepared for you today is just some insights that we've gathered from this cohort of over 500 patients and specimens that we have. That there's heterogeneity in terms of the granuloma diversity, the chronic inflammation, fibrosis, cavitary and bronchiectatic alterations, tertiary lymphoid structures, which I think is very important when it comes to the pathogenesis. There are metaplastic transitions and aberrant epithelial repair, which we can observe and I think is contributing to the pathogenesis, and the pulmonary hypertension, right? Now, I mentioned that our cohort is representative of all the comorbidities, but many of you will already start being skeptical how much of the alterations are due to the comorbidities. So for this presentation, I've selected a cohort that's actually HIV negative, because post-TB lung disease is not informed or driven by HIV exclusively, nor is it a phenomenon of drug resistance or susceptibility, and not necessarily due to comorbidities, even like interstitial lung disease or chronic obstructive airway disease. So the granuloma diversity mimics what we see in active disease. One would assume that these granulomas are going to be completely healed, but we have persistent non-necrotic and necrotic granulomas in the mix. The inflammation varies. It can be dense or sparse across the lung tissue with fibrosis, And as I said, there can be cavitation with or without colonizing or invasive fungal infection, usually Aspergillus in our setting. And a grading scheme for the fibrosis is definitely possible using microanatomical classification from pleura to parenchyma, severity and extent. Right? Notably, it's a mixed obstructive and restrictive pattern. We've got features of the bronchiectasis, which we would expect, but also features of interstitial lung disease and a UIP pattern, right? So with fibroblastic foci and honeycombing. The tertiary lymphoid structures persist even in scar tissue in areas of dense parenchymal scarring, which is strange. So it's supposed to be immunoprotective, and from our other work, we know that TB antigen is still present even after microbiological cure, which kind of explains the presence of the tertiary lymphoid structures, but this is driving ongoing inflammation and fibrosis, contributing to the remodeling that's occurring in the background after microbiological cure. Metaplasia is supposed to be an adaptive response, but the epithelium, if it persists, it runs the risk of becoming neoplastic, and the epidemiology tells us that TB survivors are at increased risk of cancers, and this might be the explanation for it. So we've got a pathogenic mechanism here for that that warrants further investigation. And then my favorite, pulmonary hypertension, which is consistently seen in all our specimens. And again, it's a mixed bag of etiology from plexiform lesions that would speak to primary arterial hypertension, to chronic thromboembolic phenomena, as well as recanalized vessels. So before I step down, and my time is up, the morphology does matter. You know, we often say when we talk of structure that form follows function, so it stands to reason that dysfunction will follow deformation. So if you disturb the structure, you're going to have a disturbance in function. Morphology is a product of pathogenesis, so it tells us what comes before, it predicts progression, but it lacks precision, and that's why we need pathomolecular and a multi-omic characterization so that we can correlate against the clinical and radiological parameters. And we need preclinical models for mechanistic studies. So we put our money where our mouth is, and we've collaborated with Amy Barzak, who's also here in this audience, to develop a mouse model for fibrosis. In the meantime, my 2 cents to yesterday's conversation, the heterogeneity does add to complexity, which was the title of my talk, but I think it should be embraced as a feature rather than as a challenge or as a conundrum. Just accept that it's part of post-TB lung disease and define it accordingly. And that consider defining it as a spectrum. So you're moving from, that speaks to a trajectory of disease, so going from abnormality to disease. We advocate for collaborative research, and as such, we've made our tissue resource open to the world. It's now a global research resource in TB, and that's the website for it. We'll add a QR code. I noticed this crowd likes QR codes. And a reminder that as pathologists, we look for patterns. And when we recognize patterns, we always say, this looks like that disease, and that looks like that disease. But when it resembles something, it also resembles the pathogenesis. And similar treatments may be of value. So we should learn from the patterns and other models of disease. And with that, I leave you.